Hello and welcome to another episode of a special joint venture between Social Media Docs, SoMeDocs, and Daily Ventures titled Stigmatized, in which we discuss stigmatizing aspects of the medical profession and the individuals who have faced many harrowing circumstances. And today, I'd like to welcome Dr. Jim Follette, anesthesiologist and addiction specialist. And with that, Dr. Follette, thank you for joining us.
Thank you for having me, Jay. It's good
No,
to
the
be here.
pleasure is all ours, certainly. And I think your story is one that many people should know and should learn from. And that being said, would you mind going into your background, telling us how things materialized over the past few years and where you are now?
Sure. I am board certified in anesthesia. I finished medical school in '79 and did an anesthesia residency. And so I went into practice in 19, and probably my best job ever was out in Indiana, where I was the chief of a department of anesthesia. But unfortunately, one time I tried fentanyl, and it was not good for me. And so I used it for a few weeks. I ended up going to treatment down in Atlanta. And fortunately, I have now 18 years of recovery. Um,
Congratulations.
Thank you. The problem was the last time I relapsed, which was I was working as an anesthesiologist here in upstate New York, and I used tramadol for a toothache. And if you're a fentanyl addict, tramadol is like, nothing. But it doesn't matter. I realized that maybe I needed to look at and do the treatment again. And so at that point, the state board of professional medical conduct got involved. And they said, well, because you're a relapsing anesthesiologist, you can't do anesthesia anymore, which it turned out to be what God did for me that I couldn't do for myself, because I was older, I was having trouble, taking anesthesia call, and unfortunately, I did come to the attention of the Board of Medical Conduct in New York, and I had been on the board back in the early to mid '90s. I was on the Board of Medical Conduct. And in fact, back then, their attitude about recovering physicians was much different. The idea was this is a disease. We got to get docs healthy and get them back to work. However, that shifted. So when I relapsed in 2000, they said, well, you're done. You can't do anesthesia anymore. And I get the feeling that they would have preferred that I just quit medicine altogether. I remember I went for my hearing for probation. I was on probation for 5 years. And when I went for probation, they were not very nice. They were treating me like a criminal, because I do have the disease of addiction. At any rate, when I got through that ordeal and I got healthy again, I started practicing addiction medicine. I got boarded in addiction by the American Board of Addiction Medicine, and I started practicing. And because of my anesthesia background, there was quite an overlap with people with chronic pain. So I started treating chronic pain as well, but I don't use needles. I don't do injections. I rely on primarily opiates and other adjuncts to treat chronic pain. And so this 4 years ago, actually a little longer than that, I was reported to the board again, and this time because that there was somebody, a person that made a complaint about me because I discharged him for not being following the program. And so I remember this was back in about 2012, something like that. And so they said, well, we want to see his records. And I said, well, they're protected by CFR 42, which is more restrictive, in fact, than CFR 45, which is the standard. And I said, I need you to get a release from this guy in order for me to release his records. And they had a lot of problems getting a release from him because he was in jail for selling drugs. So they ended up dropping that one. However, about 4 years ago, just before the COVID epidemic, they brought to my attention 8 cases where they thought I was mismanaging patients because I was using opiates for chronic pain. And so that we went through a hearing. I went through the hearing. The guy that interviewed me was a retired anesthesiologist who I don't think had ever done pain management, much less addiction. And, I love pharmacology. So I read all about the drugs that I'm using. I also read about the interactions. Buprenorphine, which is the component of Suboxone, is just an unbelievably important drug, especially in the fentanyl crisis, because it is stronger than fentanyl at the binding sites. So if
Hmm.
you're on Suboxone, fentanyl won't have any effect. And so that has been the mainstay of addiction treatment, let's say up until recently, and I'll get into that in a minute. So, but I also found out that when you use it for pain management, it does work, but not everybody gets sufficient relief from their chronic pain. And so, reading about it, I realized that if somebody's on Suboxone, you can add other drugs to it. And so, my classic combination is methadone, because methadone has other effects besides being a mu receptor agonist. In other words, it's not just a pure opiate. It also may have some, they used to think for a while it was what's called an NMDA antagonist, which is responsible for memory. And a lot of chronic pain is actually a problem with nerve memory and central memory as well. And so morphine is also very effective. But when, they reviewed my charts, they said, you can't use methadone with buprenorphine. It doesn't work. And I said, I've got about 30 patients where it's working. But that's the kind of thing. I started getting hit with these things where I don't think they really understood what was going on, what I was doing, why I was doing it, the way that I was doing it. And so they say, well, we don't like you using opiates to begin with because of the opiate crisis. And Jay, as you and I know, this opiate crisis, it is a problem that I think the federal government, the DEA and the FDA really dropped the ball early on when it came to OxyContin. And they said, only 1% of who take OxyContin, 1% of patients will become addicted. We know statistically that about 10% of people that use opiates might have a problem. But the FDA let them get away with it. They never censored their advertisements or any of that stuff. So what's going on now, unfortunately, is trying to close the barn door after the horses have gotten out. And here's the deal. And I just gave a talk at my church about this. There's always going to be another drug. Even if they are able to stop the flow of fentanyl into this country, there's going to be another drug. Right now, in fact, fentanyl isn't even number one anymore. It's meth, and there is quite honestly, there's no treatment for meth. Meth is a real problem because there's no specific antagonist for it. And so that, if somebody doesn't want to get sober, doesn't want to quit using, they have to want to do it pretty much on their own because there's no pharmacologic intervention like there is with fentanyl and like there is with
Yeah.
opiates. So that's what we're up against. But believe me, they're still on the let's stop opiate use bandwagon, as And I read your book, and what happened to you was a travesty, and it was certainly over bureaucratization of this problem. The DEA, they don't know what they're doing dealing with this. I mean, look at the history of in this country, the laws that have been passed. How well did stopping alcohol use
Yeah.
work with prohibition? No, all it did was empower the mafia to
Yeah.
gain a stronghold. So you can't just say, oh, you can't use this stuff and we're going to outlaw it, because that just doesn't work.
Exactly.
Really, what they need to do is concentrate on not the drug, not the supply, but on the demand. And that's the
Hmm.
problem. If people are happy, they're not going to want to use drugs. If they
Yeah.
have a future, they're not going to want to use drugs. If they're doing okay, they're not going to want to use drugs. And yet, how much money really goes into social programs? How much money, other than college, that, people learning a trade schools, that's not happening. How many social organizations like Big Brother and Big Sister are they putting out there for all of these kids that have one parent and are having a difficult time? So really, the money is by trying to stop the supply is just they're wasting their time. You
Yeah,
know,
for sure.
just the drugs that are available now out past fentanyl as far as opiates, if you want to consider opiates. There's so many things much more powerful than fentanyl even out there,
Yeah,
and there's more in development. There'll always be another drug, you know. So we've got to
yeah.
work on the desire to use the drugs.
Mr. Follette, thank you so much for sharing your story. It's incredibly powerful, not just because of what you went through, but because of the resiliency that you've demonstrated time and time again. If you don't mind, I'd like to start at the beginning. You had
Sure.
mentioned that you had tried the fentanyl, and I want to contextualize your story within the broader scope of your patient care. When
Yeah.
you see a patient with substance use dependency and you go back to the time when you first tried fentanyl, talk through those moments, what was going through your head, and how that helps you empathize with your patients.
Oh, thank you. The You know, when I started using fentanyl, it became number one. I used that in place of my work. You know, I would use it at work, you know, surreptitiously, but it became the most important thing in my life, quite literally. More important than my family, more important than, you know, just about anything. And so I can understand when somebody comes in and they've got a problem with addiction. I get it. I get it. What a significant thing it is in their lives. And I also, hey, I went through withdrawal myself, and I understand that fear of withdrawal. Withdrawal was one of the worst things I have ever gone through in my life. And so I can identify with people that are afraid of going into withdrawal. And the important thing is that the buprenorphine, if somebody goes into withdrawal, buprenorphine takes them right out of it, you know. So I can identify as I have heard said and how I've said in AA, you know, I gave up everything for one thing. And now I give up that one thing for everything, you know.
I
And
love
that's so
that.
I can identify with my patients. You know, I understand how difficult it is, what they're going through, you know, the stigmatization. I still have patients that go to pharmacies to pick up their Suboxone, and the pharmacist give them the hairy eyeball, and it's like,
Mm.
wait a minute, where's the professionalism here? This is somebody that is really doing something to help themselves and to turn their lives around and doing the right thing, and you're going to be, you know, shaming them, you're going to be criticizing them. That is so ridiculous, but that is the problem in our society. The fact that I'm in recovery, I have a target on my back with OPMC, the Office of Professional Medical Conduct, and it's a disease, you know.
How do your peers look at it? You had mentioned a complaint from a patient, but your physician peers, does it affect the way they talk to you, the way they interact? Talk a little bit about how the physicians in your community saw your journey from an anesthesiologist to addiction specialist.
I wish I could say it has been more pleasant, more interesting, but pretty much I'm on my own. I don't look for any hospital privileges. I applied for hospital privileges one time to work in a detox unit at the local hospital. But because I'd been sanctioned by the health department, I couldn't get a job. This is an interesting story. My primary care doc at the time, a wonderful guy, he was the medical director of the detox unit. He had his X number, which we used to need in order to prescribe, you know, buprenorphine, Suboxone. And when I was looking for a place to set up shop back in 2000, he has a large office in a nearby town. And I said, "Hey, can I use some of your space?" And he said, "Yeah, but it's going to have to be around the back because I don't want those patients in my waiting room." And I think, wait a minute, you know, what kind of stigma? You know, give me a break. You know, here you are, you run the detox unit, and yet you think that, you know, that people that have an addiction problem are less than. You know, it's a shame. It's a shame. And and I think really that one of the reasons the health department has been on me, and I'm still under investigation, Jay, that is still not, you know, finalized. If it comes down to the fact they want me to go to hearing, I will do it because I think I can justify whatever I'm doing. You know, the first time when I had my hearing back, you know, 3.5 years ago, I sent them like 10 articles to justify things that I'm doing, like using methadone or buprenorphine, like using, do you know that if you have untreated ADHD, you're 3 to 4 times more likely to develop an opiate problem because there's a connection with the inappropriate dopamine in your brain that causes, relates to both diseases. But putting somebody on, Adderall or something like that, the health department went nuts. You're giving these addicts another addicting substance. And the thing of it is, what, you don't get it. You don't get it that they need that in order to get healthy. So they,
Dr. Follette, let's
sure.
touch on it. And I apologize for interrupting, but I think
Oh,
it's
no
such an
problem.
important point.
Sure.
A complaint is filed against you.
Yep.
You respond with clinical studies with
Yeah.
ostensibly medical evidence.
Yeah.
Talk about how the clinical studies are perceived by the board relative to this perception of medication X is addictive, therefore Y. Talk about that logic that's used
I
in the face of clinical medicine.
Dude, I have no clue. I think I have a really good attorney, and he's not my attorney anymore because it doesn't do any good to have an attorney. And he's an MD, LL, what is it, LLD, whatever,
LLM.
LLO, and he's such a knowledgeable guy. And he said, Jim, they're still practicing 1990s medicine. Most of the guys that sit on the board are retired people that haven't kept up. They're not interested, you know. And so when you approach them with, listen, that first of all, a drug is not a drug is not a drug. That is a fallacy in addiction. Drugs are different. They have different effects on the brain. If you're an opiate addict, you tend not to like stimulants, unless you have ADHD as the common thing. I never liked uppers. That wasn't my thing. I like fentanyl, unfortunately, which is available as an anesthesiologist. So the problem is we have people that are making these judgments, like the DEA in your case and like OPMC in my case. Unfortunately, the DEA hasn't come knocking on my door, but I know that they probably keep track of the amount of opiates that I prescribe. But OPMC just has this blanket attitude. Opiates bad. My most recent case that I got named in, and this is very sad. This is a guy that had been seeing me since 2017. So he's been my patient for 7 years. Really nice guy, big guy. He's about 6'2" or 6'3", weighs about 280. Used to be a hockey player, and so he's broken all kinds of bones. And now in his early 50s, he has got arthritis to beat the band from all of his previous injuries. He had a failed back. He'd had back surgery for herniated discs, and he had failed back. We were managing him on opiates. He's very opiate savvy. He knows what works, knows what doesn't, and buprenorphine to keep him safe so he can't overdose on the others. But he ended up, an orthopedic surgeon convinced him to have another surgery on his back, which was a travesty. And so he was great for maybe a month, but then the pain got worse because he got a lot more scarring, a lot more nerve entrapment. And they asked me when they interviewed me, is there anything you would have done different? I would have said, yeah, please. I would have told them, please don't get additional back surgery. It's not going to help. It's only going to make things worse. At any rate, when he was in the hospital post-op, one of my former anesthesia colleagues was in charge of the pain program at Upstate in Syracuse. And rather than calling me and saying, hey, this guy is on opiates and buprenorphine, what's going on? They just assumed that the guy was being mismanaged, and they refused to give him anything for at least 6 hours, he said. So he was in excruciating pain immediately post op because they wouldn't treat him. Yeah. And so the thing about chronic pain that you learn is if you have some episodes of acute pain, it makes your chronic pain worse. Because chronic pain, a lot of it is memory. So if you now have some more acute pain to remember, it's going to be miserable. At any rate, he's the guy that made a complaint against me, not my patient, but this other anesthesiologist who was always on my case. He was not a good guy. So the health department has to investigate complaints. I get that. and they don't care where it came from. They didn't ask my patient anything about it. And, so that's where we were the last time. So that one's still pending too. It's still out there.
So do you feel like the physicians in your area, those who know you, see you mostly through certain past incidences as opposed to the physician that you are and what you're trying to do today?
Oh, absolutely. Absolutely. I'm a marked man. I get that. And that the thing of it is in recovery, I've learned that what other people think of me is none of my business. And so,
Yeah.
and they don't, here's another thing, it used to be the American Society of Addiction Medicine used to have a board, the American Board of Addiction Medicine, which I took and passed. The one of the other specialties started offering a board, a subspecialty board in addiction medicine, but because my license had been restricted because I have a mental health issue, addiction, I couldn't take that board. I had to have a perfectly clean license. So, really? I mean, I've been in recovery for 18 years now. Give me a break. But the state doesn't go back and say, "Oh yeah, no, you're doing good now." So, and other physicians, I mean, there's a YouTube video about me. Syracuse physician, former addict, now treats other addicts, and they did a really nice newspaper article about me. None of my colleagues called and said, "Jim, you're doing a great job." Whatever, they. Yeah, go ahead.
Let's talk a little bit about that mindset because, truth be told, I face it, and you know that I face it
Sure,
as well. So it's
absolutely.
something that we both kind of face on a daily basis. Um, what I feel is that the physicians I know and that I interact with are well intentioned physicians. They mean to do well for the patients and they want to re engage. But the moment anything DEA related comes up, the conversation turns silent and there's an awkward pause or an awkward forced shift to discuss anything and everything else. And there's this almost kind of instinctual tendency to just avoid talking about anything or avoid even remotely addressing it. Can you talk a little bit about how you experienced that and what efforts you've had to maybe parse it out or at least overcome it?
There is, like you are saying, Jay, there is a tremendous fear out there of bureaucracies that have to deal with medicine, like the Board of Medical Conduct, like the DEA, because they're faceless, and yet they have unbridled power. Nobody is overseeing what the DEA is doing and say, hey, wait a minute, this isn't making sense. Why are you doing this? Because they're a bureaucracy. And I have a really good friend who is actually a Supreme Court judge, a local Supreme Court judge, and he's also in recovery. So we have some common ground there. And he has been investigated by the Judicial Review Board. And he said, Jim, that's the problem. The organizations, the governments have created these things for problems that they don't want to or know how to deal with. And then they give these organizations unbridled power. Who's overseeing the DEA? I'm not sure that anybody is. They're there, and they're at your door. Sorry, and OPMC. There's nobody. Technically they're in the health department, but there's no oversight. It's so that's what we're up against, Jay, and other physicians. And one problem with chronic pain in this area, I have picked up a lot of patients who had been treated by other physicians who said, I'm sorry, I'm not going to prescribe opiates anymore. There's too much risk. And some of these people were on like nothing. I mean, they were on minuscule doses of hydrocodone, a little bit better than, Motrin, and yet it was working for them, but their doctors say, no, I'm done prescribing controlled substances. And my own physician, my own primary care doc, will not prescribe controlled substances. Not that I need them, but she has made it clear, don't ask me for any drug. Why? What's that about? Just because they're controlled doesn't mean that they're not very useful. There is
Yeah.
nothing better for pain than opiates. Sorry, that's the way it works. God put this, dopamine system in our brain, that's stimulated by the opiates, and it works for pain, you know? So,
And Dr. Follette, you mentioned early on in the conversation a very important point. You were on the medical licensing board at one
yeah,
point in your career,
on the discipline
and
board.
on the
Discipline board.
disciplinary board,
Yeah,
nonetheless.
right.
And you mentioned that they had a very different perception of addiction among physicians than they do now. Can you juxtapose that, your position on the disciplinary board, you now facing the disciplinary board, you seeing how addiction is perceived in the past and how it is now, contrast just the viewpoints at an individual level and at a policy level?
That back then, when I was on the board, actually, we had a subcommittee on substance abuse, and the attitude was get them healthy and get them back to work. I think with the opiate crisis, that there is now this overreaction in dealing with anybody that is prescribing opiates, that there is a lot more oversight, a lot more. I don't know if you remember, that back in the day, I mean, when you went to the emergency room, you came home with a 30-day supply of oxycodone. It just happened. Now they have cut back to the point where, which is not inappropriate. I think it's necessary to monitor, but I think that the problem is it has moved it from a medical ethical to a criminal type situation. When one of the opportunities I had to for remediation was I'd pay a $10,000 fine. For what? What have I done that would warrant a $10,000 fine? That's punitive. Why are you being so punitive with me? I'm only trying to help my patients. And because I believe that opiates work well for chronic pain, that's what I use. So the attitude really, I think it started changing maybe in the 90s. Maybe as all of the stuff with Purdue Pharma, made the press and everything, everybody started being really negative about opiates and everything and said we're over prescribing and overdoing and all of that stuff. I do think we need to monitor. I do think we need to be careful about it, do it appropriately. But I think to automatically vilify it is just, it doesn't make sense to me. But that's where we're at, Jay. As you know, that's where we're
Yeah.
at.
There's this saying, a former addict can in many ways become a patient advocate because their lived experiences is an asset, is a form of expertise, if you will. Why is it that in the medical community, your experience doesn't give you a certain expertise or a certain heightened empathy when you're treating with patients? Has that issue ever been discussed or at least brought up?
Well, here's the deal. Most doctors don't want to deal with drug addicts. And for some reason, they probably have a negative feeling about doctors that are willing to deal with drug addicts. That they feel that, hey, maybe they're, that this guy is just feeding them drugs. Well, I am. I'm feeding them Suboxone, to keep them
Yeah.
safe. But, that they don't get it. It's kind of like we've, it's no longer, I don't know, when you were in medical school, did you even have any discussion of addiction? I know I didn't when I was in med school, you
It was
know?
one lecture of pharmacology where we talked about the mu receptors, and
Yeah.
you just kind of learned it to pass the test, and that was about it.
Oh, yeah. Yeah. So it wasn't considered negative. I mean, it wasn't considered a big deal.
No.
Now it is a big deal. The number of people that die from this disease, every year, it's still over 100,000 a year, and quite honestly, Jay, it's going to be worse with meth. The difference is, opiates can kill you if you take too much. Meth just kills your brain. I have a couple of patients who started using meth, and now, one of them took a baseball bat to his girlfriend's head, and he's now in prison. And the other guy, he comes to my office, to stay on Suboxone, fortunately, but he's like a vegetable. He's in, I consider him catatonic schizophrenia. He will just sit there, blank, and I say, "How you doing?" "Fine." "What are you doing these days?" "Nothing." "Where are you?" "How's life?" "Fine." And it's like meth rotted his brain. And it's sad, and that's next. That's next. And so,
Yeah.
maybe the emphasis will shift, from opiates, hey, maybe opiates weren't so bad after all, into something else. Because it really did. But, they have always had this weird attitude with the government about opiates. Just look, I researched the history of methadone, which is fascinating because for a long time, methadone was the only thing that they would use for opiate addicts. And to get methadone available for use in clinics, as restricted as it has to be administered, although I think they're working on a lot to change that, had to be administered in clinics. They tried to pass a law that since it was being used for addiction, you could no longer use it for pain management, and that got squashed by a court. But that's the attitude that the government has. They say no, this, you know, drugs bad. Let's we don't even want to consider that they might be useful at this point. Because of the fear of the addiction problem.
In
So
America, we tend to look at things with the lens on the present and tend to exclude some of the past tendencies or past patterns. Is there something uniquely American about our take on addiction that perhaps has historical roots, or you think that there's something unique about this time with the opioid epidemic that's causing these new behaviors?
I think that this has been an ongoing problem. If you read the history of the laws that have been passed about addiction, and what was it, 1914 is when they passed a law about importation or manufacture of heroin. Great Britain still uses heroin. It's used for addiction. It's also used for pain. Diacetylmorphine. I don't think they call it heroin. They call it diacetylmorphine, and it's a great drug. Look at what Portugal did. Portugal said we're going to take all the legal aspects of drugs off the table, and their problems went down. The number of patients with hepatitis C and HPV and all of the sexually related, you know, went down. And so decriminalizing it has been an important thing. Our country is not going to decriminalize it. There's no way. I mean, look at the struggle they're having decriminalizing marijuana. I mean that's been a real interesting thing. New York State state started with medical marijuana, and now you can use it recreationally. I still have patients that come to get certified because if they're going to the dispensary, they know what it is. They know that
Yeah,
it's not laced with fentanyl. They know it's not laced with meth. They know it's not garbage. And so that there is that going on, but it's still federally, it's still a crime.
yeah,
They haven't legalized it. So I don't know. I think in some ways we do have kind of a puritanical society when it comes to a lot of issues that really cloud the rational approach. And
yeah,
that's what we're facing. That's what you faced. That's kind of what
yeah.
I'm facing. So
Let's transition and talk a little bit more about your resiliency and just your ability to overcome, because I think that's extremely important. So, when you realize that your path as an anesthesiologist is coming to an end, you transition into addiction medicine. Many
right,
physicians would have simply just called it. You were at an age where you could have potentially retired and walked off to the sunset, but
yeah.
you chose to come back and you chose to redefine yourself. Go through that emotions when you first made that decision to say, I'm going to go into addiction medicine.
Well, it started in 2000 when I was just getting out of treatment. And they had told me, well, Jim, you can't do anesthesia anymore, which, like I said, that was kind of a godsend because I was getting too old to be up all night with, trauma. And so quite honestly, I was kind of looking for a way out. But the thing of it is, I for a while, didn't know what I was going to do because I was only 58 and I really wasn't ready to retire yet. I had been most of my career is in academic medicine, which, that's not the top paying. So I wasn't ready to retire. And so I had the number one thing at that time, though, was really building sobriety. And so I started doing a lot of volunteer work. I volunteered at Habitat for Humanity. I volunteered at Rescue Mission. I volunteered at Meals on Wheels. And that really got me into a different way of thinking. it got me into being more empathetic. I think that's one thing that I was lacking as a physician. I was kind of arrogant and selfish, and I said, "Yeah, I'm smarter than anybody else in this room," and that rubbed off on my approach. And really, getting down and volunteering really helped, and I loved it. Went down to New Orleans and Biloxi, Mississippi after Katrina. Then, when the time was right, I suppose when I was healthy enough, when I had gotten sober enough, I started thinking about doing something with my knowledge, not only of medicine, I love pharmacology, so I get drugs, but also to use my own experience, strength, and hope, to help other people that are suffering. And so that's it. So it took me that I got censured by the health department in 2000. I didn't return to medicine until 2009, almost 2010. And they, quite honestly, I don't think they were happy about it. I think they would have preferred that I just rode off into the sunset. But I did 5 years of monitoring, where I had to pee in a cup for 4 times a month for 5 years. And I did whatever it took. It was worth it because I thought I still had a lot to offer in medicine, working with people. Quite honestly, most doctors don't want to deal with addicts. Most
Yeah.
doctors don't want to deal with patients with pain because the automatically, and I think you talked about this in your book, you automatically distrust people that are coming in that are expecting some kind of pain relief, just like people that come in and say they're addicts. Well, that my first response is to trust. I
Yeah.
really trust until I learn that I can't. And one of the responses I have for OPMC where they say, "Gee, we don't see a lot of urines and pill counts in your studies." I said, I trust my patients. Don't you
Yeah.
guys? Don't you trust your own citizens? You know, so, but that's the problem. That lack of trust, and that's one of the big things I took out of your book is that I think that organizations like DEA and OPMC expect us to be cookbook. They don't expect us to treat medicine like an art, and a
Yeah.
science. And that's unfortunate because it has always been an art. Back when they used to
Yeah.
use leeches, they didn't work very well,
Yeah.
but at least they were
Yeah.
trying, you
Yeah.
know. So, and there are uses for leeches these days, when you reimplant a digit or something, you put leeches on it to stop the congestion. But so we're
Let's
learning.
We are learning. And I think one of the things we're learning more and more about is addiction in the medical community among physicians. We talk about burnout, we talk about moral injury, and that's just now becoming acceptable to discuss. But addiction in the medical community among physicians is still quite taboo. Uh,
Yeah.
have
Yep.
people approached you asking for advice, and have people sought your counsel that were maybe too scared to bring it up or too scared to let it out? Without naming names, can you talk a little bit about this kind of silent pervasiveness of addiction in among physicians?
Oh, sure. Just like any group of people, probably 10%, that I was in treatment the first time down in Atlanta, and there were 90 of us on a Saturday morning sitting around a big room. And boy, talk about egos flying back and forth. But in my practice, I have treated a few physicians, one in particular, really super nice guy. He's an oncologist. He was using opiates for back pain, and it got ahead of him, so that he was enjoying them. And he came to me and he said, I need help. And we got him on Suboxone. He was with me for 3 years. Now he has tapered off his Suboxone. He's doing great. He's still in active practice. And of course, we kept it hush hush. In fact, I'm close with his pain doctor, and his pain doctor said, yeah, he needs help. He's overdoing it. And so, I was right there, and he was willing. That's the good thing. A lot of times, if you have a license that's in jeopardy, I think you're much more likely to get help. I know for a long time I put being in recovery on my CV because I thought, well, that gives me credibility, now maybe they won't take my license for being a drug addict. But they're still after me for that. So it hasn't worked recently.
Well, that's interesting because you gave one example, one scenario where physicians worked together and helped a physician who had a certain dependency. And you're also contrasting that with a bureaucratic organization that's looking at this as if you're a marked man. Can you contrast a little bit between the physician on physician support network versus the imposition of the bureaucracy and how that just changes the whole calculus?
I think one problem is that physicians tend not to be very political, and they tend not to get involved with things that are on a state level. Look at how many representatives or how many um, senators. I think there's maybe one or two in the whole Senate. We tend not to be political animals. We're there to treat our patients. We're not there to have rallies and make movements and stuff. So it's tough. We're just not used to doing that. And I think that the thing of it is when somebody brings this up, like you have in your book, which I think is a landmark in saying, hey, we need to take a look at where we're at with this stuff. I'm listening to a really good book right now called Drifting into Failure. And I don't
Hmm.
know if you've read that. Have you heard about
I've
it?
not,
It's
I've not
it's
heard of
a
it.
yeah, it's a guy who looks at failures and where they come from. And the problem is in medicine, we're drifting into failure. And part of the problem, and he cites a number of things in industry, like the Deepwater Horizon and how BP kind of turned a blind eye to all the safety mechanisms in order to make more money or whatever. But he's analyzing it and he's saying that's the problem with organizations, any organization, over the course of time, they get complacent and they don't want to start over and look at things new again. They're just building on the old, making laws on top of laws on top of laws, rather than going back and say, oh, wait a minute, let's go back and revisit some of these existing laws, and maybe they're off the mark in 2024. But that just doesn't happen. So I think that the problem is the fact that we're not vocal. We're not out there. We tend to run away. We tend not to say, for example, don't prescribe opiates, don't prescribe controlled substances because the DEA or the OPMC will look at you. That's kind of, wait a minute, they're important weapons in our battle against certain diseases like chronic pain, but that's unfortunately, a lot of doctors put their head in the sand and say, yeah, it's not my problem, I'm just not going to deal with it. So it's tough to be an activist. We saw a few activists during the COVID crisis, and you can see what happened to a number of them. A number of them lost their jobs. A lot of them, there was even a few that lost their licenses for speaking out against the way it was
Yeah.
being managed. So I don't know, Jay. It's a difficult problem, and to get other doctors to wake up. Unfortunately, there's not, since there's only 10 to 15% of docs that are going to have a problem. They're not going to be vocal about it. You know,
Yeah.
I have been willing to be vocal. I have been willing to put myself out there. I've been willing to have a reporter write an article about me and do a YouTube video about me and stuff. I think that's part of my, as a recovering physician and as a recovering person. I think part of my responsibility is to help other people with their disease. So that's.
Well said. Dr. Follett, in the remaining time that we have, can you impart some concluding words of wisdom for the listening audience, whether it's a physician in recovery or a physician unsure of how to deal with a colleague who may be going through recovery, may be dealing with certain patients that would be perceived to be quote unquote those patients? What advice can you give to those listening to say, listen to my story and hear my words?
Yeah. I'm certainly more than willing to help anybody that reaches out. One of the problems that we have in New York State is there is an organization that's part of the medical society called Committee for Physicians' Health. And back in 1992, I was actually the medical director, but it is under OPMC's thumb. And so physicians don't want to refer other physicians to that body, which used to be helpful. because there's that fear of repercussion. There's that fear that, once they're in CPH, they'll get turned over to OPMC, and they well might. So they look at it as a disciplinary problem. And it's not, it's a medical problem. It's a health problem. So Jay, I don't know, because the things that we have set up to try to help other physicians tend to fall into the category of, well, in order to have the support we need from the state, we need to become disciplinarians ourselves. This is not a disciplinary problem, it's a health problem. It's a medical problem. It's a disease. you know so I don't know. Where to tell people to turn. I don't tell them to go call CPH anymore. I think that would be a mistake. It is much better if there are knowledgeable physicians who can suggest, hey, I know this guy who does addiction in Fayetteville, why don't you give him a call? He can help you. And I do get a lot of word of mouth, referrals and stuff. So, but that, I don't know, Jay. I'm in a minority, and it's sad. You and I are in a minority, my friend. Trying to do things differently. We're bucking up against the big bureaucracy of medical care. You say, I
Yeah.
was in where I was the chief of anesthesia was in Evansville, Indiana, and boy, they took a very, very conservative approach to me when I had my problem. Most doctors at the time down in Atlanta, where I went for treatment, they were supposed to get healthy and then go back to work. The 3 days into my treatment in Atlanta, I got fired. And that hospital down in Evansville actually had a treatment program, which I thought, well, that's not good advertising. If patients that come to you end up, getting fired, they're not going to want to come to your treatment program. But that's the attitude, and that's more pervasive now, I think, than it
Yeah.
was.
It's sad because the more we advance technologically, the more backward we seem to be going in terms of our conceptual framework.
Yeah, I agree. I agree. There's not a lot of empathy out there. There truly isn't.
Dr. Follette, I want to thank you so much for your time, and as always, it's great speaking with you.
Well, thank you, Jay, and thanks for your book. It has really been eye-opening. You've put a lot of work into it, and it really tells a good story. So
Thank you, sir.
you're welcome.